Okay, so I mean that this ESMO consensus is very, very easy to retain. It's probably one situation where it's the most simple. The key message is at each time you perform removal of a pancreatic tumor, you have to give chemotherapy as adjuvant treatment for patients able to receive it. And on which this is based, very simple, 3 slides, 3 studies. The first one, ESPAC1 study, a little complicated study, but the key message of ESPAC1 was when you give chemotherapy to patients after surgery, you improve the prognosis as compared to surgery alone. In ESPAC1 study, chemo was 5-FU and folinic acid. Second study, CONCO-01 study, German study, comparing surgery alone versus surgery plus gemcitabine. Same figure, same results. You improve the outcome of patients with chemo as compared to only observation. Third study, third slide, ESPEC3, comparison in adjuvant situation of gemcitabine and 5-FU and folinic acid, no difference at all in terms of results. And if we try to summarize on one slide these 3 slides, it's very simple. The key message is that you are able to double the 5-year survival rate by giving chemotherapy after surgical resection of pancreatic adenocarcinoma. It's very interesting to see that the 5-year survival is consistently around 10% for surgery alone, and a very, very, very consistent 20% 5-year survival year in the arms of patients treated with chemotherapy, 5-FU, either gemcitabine. So it's very, very easy, and I have absolutely no comment concerning the ESMO recommendation. But this is very easy at the present time, and probably it will be more and more complicated. And I will take 5 or 6 minutes in order to project which could be beyond the ESMO recommendation, the situation in the following months. Some slides will overlap the topic of Dr. Sofferlein. I'm sorry, but I mean it's also based on data concerning adjuvant situation. As you perfectly know, gemcitabine should enter into the tumor cell to be active and should be triphosphorylated to be active. And therefore, we have at least 2 limiting patterns, HENT1, penetration of gemcitabine, and DCK, transformation of the prodrug gemcitabine to the active drug gemcitabine. The first slide showing the value of HENT1 as a predictive factor of activity of gemcitabine was given with the RTOG study. Very simply, on the left on the slide, you have the outcome of patients receiving gemcitabine in adjuvant situation according to the status of HENT1, HENT1 high or HENT1 low on the top of the slide, or HENT1 sorry, it's difficult for me to see here. Okay, HENT1 high or HENT1 null on the top of the slide. On the right slide, you have the same figure for patients receiving 5-FU. We also have an experience between the France and the Belgium with a huge series of more than 400 patients. These patients had a resection of their tumor, and they were separated in 2 groups. The first group without any adjuvant treatment or with treatment in adjuvant situation without gemcitabine, and the second group treated with a gemcitabine-based treatment. And we have the same figure. In the gemcitabine population, as you can see on the slide, the overall survival is really different between patients with high HENT1 expression as compared to patients with low HENT1 expression. And in the right part of the slide, it's the same figure concerning the expression of DCK. Better prognostic for patients with a high expression of DCK, worse prognostic without expression of DCK. This is a proof of a predictive factor of HENT1 for gemcitabine activity. And the proof of the non-prognostic factor of HENT1 is done by this slide, where for the non-gem population, patients receiving either 5-FU or nothing, as you can see, there is absolutely no difference in terms of outcome for patients with HENT1 high or HENT1 low. And it's also the case on the right side of the slide for the DCK expression. As Thomas mentioned just before me, this was one more time confirmed during the past ASCO meeting by John Neoptolemus concerning the GEM expression, the hand-to-hand expression for the SPAC1 and SPAC3 studies. He finds the same figure with the difference in terms of survival according to the expression of hand-to-hand for patients treated by gemcitabine, and no difference at all for patients treated with 5-FU. A little more disturbing topic should be done at the present time, because we have some troubles for the diagnosis of hand-to-hand. I have no time to enter into detail, but at the present time we have one mouse antibody and one rabbit antibody, and maybe there is some differences between these two antibodies. And unfortunately, at the present time, we cannot be sure what's the best antibody to test hand-to-hand. And another confusion is probably done by the score of John Neoptolemus with 4 scores, 0, 1, 2, and 3+, while for the French-Belgium study and for the RTOG, it was high or low level. So there is some methodology to be improved before to enter that in a clinical practice. However, we can probably perform some hypotheses. If we look at the results of the RTOG, the AIO, or the LEAP study, we have around 2/3 of patients with a hand-to-hand low or null. It was also 61% of hand-to-hand low or null in the French-Belgium series. Then we can say that maybe gemcitabine should be considered as a placebo for 2/3 of patients. We are here in an adjuvant situation. I have no time to enter in the debate of the metastatic situation, which could be slightly different. But in adjuvant situation, there is a consistent 2/3 of patients with a hand-to-hand low or null expression, meaning that gemcitabine is unable to penetrate into tumor cells. It means also that if you use a gem combination, probably it's not a gem combination, but it's a single agent treatment. So what are the impact of this hand-to-hand story for the ongoing adjuvant study? The US Lab 07-like study, I mean, it's closed, or it will be closed, Margaret? It's in adjuvant situation, the study comparing gem plus or minus chemoradiation. Okay, so we will Skype this one. But for the SPAC4 study, for instance, which compared gem plus CAPE versus gem, at the evidence for patients with low moderate hand-to-hand expression, gem plus CAPE will be better as gem without any study. And it's also the case for the French study comparing FOLFIRINOX to gemcitabine. It's an evidence that for those patients with hand-to-hand low or moderate expression, FOLFIRINOX will be better as compared to gem. So it will probably request, at least for future study, stratification and maybe some decision based on hand-to-hand expression. This is a proposal for patients with hand-to-hand high, CDK high. So gemcitabine or gemcitabine-based treatment is probably a good indication. But for patients with hand-to-hand low, probably 5-FU-based treatment should be better as compared to gemcitabine. So this is one step. Another step is a SPARC story, a little more complicated. In this publication of Infante and collaborator in 2007, they showed that when we have a stromal expression of SPARC, it's a worst prognostic factor for patients with a complete resection of pancreatic cancer. Not a tumor, but a stromal expression of SPARC. You are now familiar with the MPAC study, where gem plus Abraxane demonstrated a better outcome as compared to gemcitabine in metastatic situation. And if we come back to the phase 1/2 study performed by Dan Van Hoof before the phase 3 study, we had very interesting results where for patients with a high expression of SPARC in the stroma, the nab-paclitaxel had a better activity as compared to the gemcitabine arm alone. So, as a better activity compared to patients without SPARC expression. So it's another example where a worst prognostic factor is translated into a positive predictive factor of activity for a new drug. It's the same story as compared to HER2 in breast cancer, for instance, with HER2 and trastuzumab. And finally, more complicated too, as a result of the recent Japanese study, the JASPAC-01, presented in ASCO meeting, comparing gemcitabine versus S1 with a very, very, very clear difference in terms of outcome. And we have also here to be very cautious because maybe some polymorphism and differences according to race, Asian versus not Asian patient, should be considered. Anyway, there is additional question, no time to go deeply. What's the place of a neoadjuvant treatment? If yes, which type of neoadjuvant treatment? What's the place of chemoradiation therapy for patients with L1 resection? And what about additional targets? So to conclude briefly, adjuvant treatment with 6 months of gemcitabine remains the 2013 gold standard after pancreatic cancer resection, but probably and hopefully for a short time. The very early next future will be based on molecular approaches, end-to-end, DCK, SPARC, DPD, whatever you want, to customize treatment and finally improve overall outcome of pancreatic cancer patients. Thanks for your attention.